Good morning, everyone. Thank God we are doing my presentation. Well, today our roundtable will be about management of balance disorder. It was supposed to be having 3 speakers, but unfortunately Professor Ramos cannot make it. So we have Professor Marco Mandala from Italy and Professor Friedrich Ihler from Germany. They will give us 2 talks, and I will make a very short intro about the topic. Of vestibular medicine embarrasses a wide approaches to potentials of vestibular symptoms. This management is based mainly on latest research, clinical practices, patient outcome assessment, and future directions. The causes of vestibular disorders is a wide variety of causes, and all of them are intermingled together. There is no single cause for balance disorders. Starts from the inner ear, brainstem, cerebellum functions, cerebellar networks, and even systemic modalities could be involved in this presentation of symptoms. In the recent years, we have experienced a lot of changes in the definition, availability of new guidelines, and even in the management and the diagnostic procedures. We have new guidelines for already existing disease. We have new revision of existing guidelines, increased availability of guide practice, and introduction of guidelines previously addressed into unaddressed conditions. There is a new hierarchy for vestibular examination that starts with vestibular reflex activity assessment, vestibular processing and singular intermodulation, vestibular integration, and ending with vestibular cognition. Clear assessment and treatment result based on medication, surgery, and vestibular rehabilitation, which was the basic 3 pillars of management of any dizzy patient, now extended to electrical stimulation, vestibular implants, neuromodulation, using of virtual reality, and a lot more to come. This gives us an integration of diverse research findings ranging from genetics, imaging, and socio-demographic studies. This was my short intro to paving the way to my dear professor. We will start with Professor Marco Mandala in a very interesting subject about cyber sickness, which is one of my nightmares during using my laptop for a long time. Please, Dr. Mandala.
Thank you very much to the President and Moderator of the session, and thank you very much for the invitation to Professor Badr, Mostafa, and all the organizing committee. Well, I must say that I'm really in the future direction part of the roundtable, so I will talk about something that I think that will be much more common and we will have to face in the future. And these disorders, well, that could be to some extent paraphysiologic as motion sickness. It's a kind of motion sickness that is called cybersickness. It can be called cybersickness or visually induced motion sickness. In the meantime, you will see this YouTube video that it's pretty scaring. If you see some of those guys that are driving autonomous car driving while wearing virtual reality or augmented reality glasses. This is a disorder where visual stimulation may be presented via virtual, augmented reality devices, simulators, or more and more of these devices that are coming to right now to our everyday life. And I will, differently to classical motion sickness, the cyber sickness is more prominent on older people instead of younger people. You can have a look at the classification of the Badr Society regarding all the diagnostic criteria regarding motion sickness and cyber sickness. We know that the pathogenesis of cyber sickness is the same as motion sickness, so we have this mismatch between visual, vestibular, and proprioceptive inputs, especially if you are in a virtual reality environment, obviously your proprioception and vestibular system gives you different input in respect to the virtual reality device and all the visual inputs. Regarding treatment, we don't have up-to-date, really satisfactory treatment, both for motion sickness, but even more for cybersickness, since it's a new disorder. We can try to reduce conflicting sensory input. We can try to make the patients adapt with increasing stimulation in terms of time. But what right now may works better are all the central vestibular suppressant drugs that you can see here. For example, one of the best, that is scopolamine, is no more available in Italy due to side effects. Virtual reality and augmented reality has been proposed for vestibular rehabilitation, and we must pay attention, because to some extent it will also trigger this mismatch in terms of different input that should be integrated by the vestibular cortex, and cybersickness has been more and more studied in order to have some specific characteristics of the disorders. If you think to professional virtual reality player that nowadays are a star, like a soccer player, they suffer a lot, and this is something that should be addressed in the future. One of the major issues in treating these disorders is that you have to go up to where the different input for our equilibrium are integrated. And so we have to go to what is known right now to be the most important part of the vestibular cortex, that is the parieto-insular vestibular cortex. It comes from many functional MRI studies where we had a peripheral stimulus that could be either caloric, sound-induced vestibular stimulation, or peripheral galvanic stimulation, and the overlapping in terms of functional MRI of this area from this peripheral stimuli was the parieto-insular vestibular cortex. Another thing that is very important is that our peripheral system has some peripheral vestibular system has some frequency of stimulation. Those are the frequency that we all know, that goes from 0.1 up to 5 hertz, and especially from 1 to 2 hertz are probably the two strongest frequency at which our vestibular system give us a strong response. Furthermore, it's known from 2010 that patients who suffer a lot from motion sickness has a higher activity of low frequency EEG in the area of the parieto-insular vestibular cortex. We know that we can change the rhythm of some area of our central nervous system using transient alternating current. This is a kind of galvanic stimulation where you need to model with MRI to reach precisely the area that you want to treat. And this is very important because we are using alternating current. So you are not inhibiting or excitating an area, you are modulating the basal rhythm of this area of the brain. What we discovered by chance, we were doing a cognitive experiment with alternating current stimulation that is called TAX, and as a sham experiment we placed by chance on the parieto-insular vestibular cortex
our stimulator, that is a really small and comfort helmet, and we use a very low stimulation because most of the brain area cannot be stimulated below 10 Hz. So we use 2 Hz in the parieto-insular vestibular cortex. And among these healthy and young subjects, all experienced oscillopsia and dizziness. So we decided to try to understand if our vestibular cortex has a similar response in terms of frequency as our peripheral vestibular system. So we did this study where we had 30 healthy subjects around 30 years of age in mean. We modeled the area of the parieto-insular vestibular cortex, and we stimulated them with 1, 2 Hz, 10 Hz, plus a sham experiment. We performed as you can see, the posturography, the computerized posturography, as well as some questionnaires. In order to be safe that we were stimulating the central vestibular system, so the cortex, the vestibular cortex, and not anything in the periphery, we had in our experiment also patients with a proven bilateral vestibular loss, and if you stimulate the patients at 1 or 2 Hz, you get the same response of a normal subject. So he experienced both oscillopsia and dizziness. And one of the key points is that if you increase the rate of stimulation from 1 Hz to 2 Hz and 3 Hz, the patients can feel that you are changing the frequency of stimulation. If we go to the 30 subjects, you can clearly see that, for example, here at 1 and 2 Hz, you have the maximum effect, both in terms of questionnaire and both in terms of sway on the posturography, both with eyes open and eyes closed. One interesting thing is that if you use the 10 Hz stimulation, something that is outside the normal frequency at which we can stimulate our peripheral vestibular system, you get the opposite effect. This patient will improve. And this is something that was pretty strange to us during this experiment, because from 10 Hz, most of the brain area can be stimulated. But in this case, we had some cutoff of the vestibular inputs. So we decided to do an experiment. Obviously, Cybersickness is a model. You just need a visor, so a device for virtual reality. So it's an experiment that can be done easily in a lab. So we did this experiment trying to see what happens if at the same time we had our patients on something that will trigger a very strong effect in terms of cybersickness, like a roller coaster. If some of you had tried a roller coaster on virtual reality, it's something that can be very, very tough for patients that's suffering from motion sickness. And we tried to stimulate a different frequency plus the sham. So this was the condition. We had more outcome measures, so questionnaire, galvanic skin response, and whatever. And the paper is published. Here you have the results, and you can clearly see that the effect of the 10 Hz stimulation is preventing cybersickness, or it's at the worst ameliorating it in most subjects. And we have had the same results, both in terms of questionnaires, in terms of posturography, in terms of galvanic skin response, that is a measure of stress during an activity like a virtual reality roller coaster experiment. So let's come to the take-home message. Alternating current stimulation at an appropriate frequency that is outside the normal frequency of the peripheral vestibular system reduce cybersickness in most subjects. This is pretty advanced because no other therapies for such a new disorder exist right now. That could be used in many other things, could improve adherence to virtual reality training, rehab, gaming, and whatever. We will see that nowadays, probably also from a surgical point of view, we will have the help of augmented reality device or whatever. Obviously, many other studies are needed for verifying that if repeated session of this kind of galvanic stimulation might improve cybersickness in these patients. And obviously, we really need other study to better understand the mechanistic hypothesis explaining why we got this improvement in cybersickness with this transient alternating current stimulation. Thanks a lot.
Thank you very much, Professor Marco, for your interesting presentation. Although I have a lot of questions to ask you about, but we are short of time. So we'll keep our questions to the end of the session. So I'd like to thank you and present Professor Friedrich Ihler for his presentation entitled Structure and Realistic Goals in Contemporary Treatment of Meniere's Disease.
Yeah, thank you very much for the introduction and thank you for the opportunity to speak. And just to introduce myself, I'm from Greifswald University, one of the oldest universities in Europe, and it was once the oldest university of Sweden. We have a lot of brick buildings, we have nice beaches during summer and beach forests. But when I left yesterday, it was already snowing, so we also have very cold temperatures in November. I want to talk about Meniere's disease and about diagnosis, therapy, and follow-up. And when we think about structure and realistic goals, our diagnostic approach to Meniere's disease is quite structured already. You see here Prosper Menière, whose contribution was to devise that there is a kind of vertigo or dizziness that does not come from epilepsy, but from the inner ear. And he brought that forward in 1861. And during the past 150 years, it was even more refined in consented diagnostic criteria. And the last version of it was from 2015 by the International Barani Society, that formulated a consensus for the diagnosis of Meniere's disease. We see two stages of diagnostic certainty that are called definite Meniere's disease or probable Meniere's disease. They have together that we are looking for an episodic and combined dysfunction. Combined means vertigo, hearing problems, tinnitus, oral fullness, and it's all attributed to the inner ear. So other causes have to be excluded. We have, besides excluding other causes by MRI, only one technical procedure here, that is B for definite Meniere's disease, that is audiometry. Most of the other points by diagnosing Meniere's disease are by anamnesis or taking of the medical history. In our practice, we try to structure that by handing the patient's diary. We call it Schwindeltagebuch or dizziness diary, where the patients can enter when they experienced vertigo episodes, when they experienced hearing loss, and additional symptoms. And we find that very helpful. When we looked into a case series during my time in Munich. We had 96 cases of Meniere's disease, and 96 cases where we, as experts, attributed it to Meniere's. We found 31 cases, almost 1/3, as definite Meniere's disease, and 36 patients, that's more than another third, that showed probable Meniere's disease according to the current guidelines. But almost another third of the patients where we diagnosed Meniere's disease and all other causes were excluded did not fit into the current diagnostic criteria. So we definitely have the need to improve the criteria, and we're looking forward to the next version. There is a very interesting option on the horizon, hydrops, as a biomarker for Meniere's disease, but unfortunately we are not there yet. We cannot correlate hydrops and the response to therapy, for example. There are a lot of questions unanswered. So how to approach the therapy of Meniere's disease? And we find it helpful in our practice to structure the wide variety of therapeutic options along the method that is employed, so either medical treatment or surgical treatment, and the intended effect of the treatment on the sensory function. So we can either attempt to preserve sensory function, a conservative approach, or we intend to destroy sensory function, so to ablate vestibular, the peripheral vestibular organ to stabilize the dizziness complaints. And we place them in a hierarchical order. So we see, of course, the medical and conservative options like beta-histine and corticosteroids intratympanically as the first choice, surgical procedures a second choice, and when we intend to destroy the vestibular end organ, a third or fourth choice. I want to show you our results with endolymphatic sac surgery, or saccotomy as it is sometimes called, since I think that is a valuable application in Meniere patients that does not destroy and is a good escalatory option when medical treatments fail. Endolymphatic sac surgery is known for decades. We are looking here on a right ear. You can see the horizontal and the posterior canal. And in the Trautmann triangle, posterior and dorsally, in the direction of the posterior fossa, you can identify the endolymphatic sac and either just decompress it, so you open the bone and leave it like that, or you do that and incise it, that's the classical saccotomy, or you put a kind of drainage inside. Here you can see unfortunately no laser. The view into the cetus of a 37-year-old lady with many years of Menière history. You can see the blue line of the posterior canal, and we can see the dura of the posterior fossa here, and you can see here as the endolymphatic sac is incised, and we put a small triangle of silicone inside to keep this incision open. We are able to preserve hearing by that approach. There is no destruction of vestibular sensory function, and in this patient we saw a reduction in vertigo spells, both frequency and severity, and hearing preservation on the right side. We see this routinely in patients. These are the data from 32 endolymphatic sac procedures, where you can see that also after many years, hearing is fairly stable, and so many patients report improvement, but a considerable share, about 1/3, does not benefit from this procedure. It's very important to counsel patients upfront. But what does improvement mean? If you talk to patients and ask questions and value their response, then you can get a good idea what improvement means, but it's hard to put that in numbers. And the American Academy proposes that we compare the number of vertigo spells in the 6 months preceding a therapeutic intervention to the number of vertigo spells in the months 18 and until 24 after the therapeutic intervention. So that means you have to follow up the patients for 2.5 years to make a statement whether the intervention helped or not. And this is unfortunately very long and not practical in a daily practice. So we are also looking forward for new ideas on this field, how to formulate real goals. We have a structured follow-up for Meniere's patients in our hospital. So we see them around every 3 to 6 months for around 2 months after that treatment, and if it is successful, the first-line treatment. But many patients require additional treatment, so we see them for a lot longer. We have established a multi-center registry for Meniere's patients. So this is Dr. Spiegel, a colleague from mine with whom I worked in Munich, and she's in Toronto in Canada now. And we have a combined approach to Meniere's patients in Munich and Greifswald, and recently Halle in Germany joined us, and some other university clinics. And since 2021, we have included 145 patients, and we try to work out new approaches on Meniere's disease. And first results might suggest patient-reported outcome measures as a possibility to follow up Meniere's patients. You can see here the data of 97 new patients. About 1/3 of them is from Munich, from Greifswald, and the rest from Munich. You can see how widely scattering the hearing function is on the affected ears compared to the contralateral ears. And with a questionnaire that asks for advanced hearing functions, the spatial speech and qualities of hearing questionnaire, we can see a correlation to hearing functions. And possibly we have to have more structured questionnaires for Meniere's patients in the future. So to sum it up, we should diagnose patients comprehensively, aided by the current guidelines. We have a lot of options, and they should be sorted hierarchically, it's mandatory to follow up patients in a structured follow-up to can say whether your treatment options helped or not. So thank you very much for your attention.
Thank you. I have a question. Thank you both. It was a very interesting talk, but I have a question to Professor Marco about the galvanic stimulation. Actually, you said you do the galvanic stimulation during triggering the patient vestibular system. Did I get it right, or just personal?
During
triggering the vestibular system, yeah, the patient will be wearing his visual reality.
Yeah, during a virtual reality roller coaster experiment. Yeah.
Is this comfortable for the patient? If,
Yeah, well, it's pretty comfort because the worst that they can feel is some at the very beginning. I did it myself, and many other colleagues from Italy or abroad come to do the experiment because they want to understand and I would like to have more clues.
as long as you're using an alternating current.
Yeah, it's a low voltage, and low frequency, so it's you can hardly feel. At the very worst, some sensation that it's like very little pinch and needles, but very little.
For how long is a session?
We did pretty brief sessions because if patients are since we had also a sham procedure and different frequency, it was like less than 5 minutes. Because if patients suffer a lot from motion sickness and cybersickness, we had a lot of patients that vomited. During the experiment. Because especially if you use 1 or 2 hours, you get an additional vestibular stimulation. So it becomes it's really a strong effect, the roller coaster experiment.
I know, I tried it myself.
Thank you.
Thank you. Any more questions, please?
Yeah, I have another question, please. I didn't get why the 10 Hz stimulation ameliorates the cybersickness.
Well, I must be really honest. As we discovered that this kind of stimulation worked also at the central level, because we already know that it works at the peripheral level since many years, we discovered it by chance. The idea was trying different frequency in order to see the effect, but it was the very first experiment of this kind. So I don't know if maybe 20, 15 Hz could have a stronger effect in preventing or in ameliorating the symptoms of cybersickness. And we just did some frequency because you cannot make the subjects, even if it's a healthy subject, to stay so long on such a strong experiment, because it can be the subjects can be really sick, and that's me, all my residents, all my PhD students, but it's something that you have to do in different days, so it can be a pretty long experiment, because then the effect of motion sickness, as we all know, can last for hours even after we stop the stimulus. Okay, thank you.
Thank you so much.